Yes, yes, Mr. Emery, I can hear you clearly, and I'm fine, thank you.
Thank you so much. So allow me to welcome you so that you proceed and we'll be able to engage with you and with your participants as you proceed. In addition, we also urge our participants to raise their questions and their concerns under the chat box so that at the end of this presentation, we will be able to answer them. Otherwise, we are happy to have you around. And we also urge you, Baraza, if maybe I have forgotten some of the information that I need to relay to the members, please feel free to share. Otherwise, Mr. Cosmas Baraza, colleague, is a specialist in histopathology and cytopathology, and currently he works with the Hopkins Crescent Hospitals, Bungoma, as the lab manager. So without wasting more time, allow me to bring him so that he can continue. Mr. Baraza, please take the stage.
Okay, thank you so much for this opportunity once again, and we are going to look at the diagnostic utility of immunoglobulins, and there are two arms on this. There is the therapeutic arm for those people who are specializing in clinical immunology. I believe they understand that. But today we're going to look at the diagnostic application of immunoglobulins. And we're going to measure in autoimmune diseases and hypersensitivity reactions, which is some of the things that we do in the diagnostic medicine that we practice. So this presentation is going to cover the following. We will be able to discuss the immunoglobulin structure and then highlight the different classes of immunoglobulins. All right, and then also list the functions of immunoglobulins. We shall describe hypersensitivity and associated disorders, because those ones that are antibody related, the classes that are antibody related, not the ones that are cell mediated. So we shall also expound on autoimmune disorders and also list the applications of immunoglobulins in diagnostic medicine. So what are immunoglobulins? The IGs. Yeah. We know that the immunoglobulins from our basic immunology in colleges, we know that they are glycoprotein molecules that bind antigens, and they are produced by the B cells, the immunoglobulin secreting immune cells in our body. They are the ones that are effective in facilitating the humoral immunity, the one that's not cellular, and also help in the complement system, complement fixation, and the formation of the membrane attack complex, those kinds of immunological aspects that are related to clearance of microorganisms and other foreign substances in the body. Now, they are essential in diagnostics for detecting infections. We usually see antigen tests, we usually see antibody tests, and they actually make use of the immunoglobulins for this particular purpose. They are also used for autoimmune disease diagnosis, screening for cancers, especially immunoglobulin producing cancers, such as multiple myeloma. They are also used for as detectors for markers for cancers, such as prostate-specific antigen, for example. Carcinoembryonic antigen, for example, is detected using specific antibodies that have been, determined to be acting against those particular antigens in the body. And then this could be in the body or in the tissues. The tissues, we have modalities such as immunohistochemistry or cytochemistry that are applied for tissue-based antigens. Now, the structure of antibodies is this way. They're usually Y-shaped. It's this structure here with a heavy chain and a light chain. And this is the heavy chain here. That is the variable region of the heavy chain. then constant region of the heavy chain, then the variable region here of the light chain. This one's the light chain, and then the constant region of the light chain is over here. And these regions are variable. These regions are variable because they are very, very versatile because they are attached to antigens. And antigens are different every now and then. So the immunoglobulins are in such a way that they are very flexible. They can be able to bind to a variety of antigens because of the variable region, which is at the tip of the antigen, of the antibody. You can see that the constant region is within the antibody structure, but the variable portion or region is facing directly to the place where the antigen is going to be binding. These regions are very versatile to allow for a variety of antigens to be bounded to that particular region to effect immunological reactions. Then the constant region, you can see that, which are usually here in the middle here. Then there is the constant light and the constant heavy chains. When we look at the functions of immunoglobulin, they are used as effectors for humoral immunity, which which means that there are no cellular elements of the immune system that are involved. Then they can also be used in opsonization. Opsonization is making an antigen more visible to be destroyed by the antigen dispersing mechanisms of the immune system. So they caught the antigen, then present it to the antigen, eliminating components of the immune system, such as the macrophages, the monocytes, the neutrophils, those ones. So after binding the antigen, it presents it to those particular effector cells, then they can be cleared. It also activates the complement system. Yeah, and the complement system ends up with the MAC, or the membrane attack complex, which causes cell lysis, bacterial cell lysis, or whichever the cell that is inflicting the human body, and it causes the elimination of that particular problem. It then kills cells directly through the antigen-dependent cellular cytotoxicity. So this one is cell cytotoxicity, but it is dependent on antibodies. So without which the cytotoxic effect of these CD8 cells will not be able to be felt. Then also works in transcytosis and passive immunity through allowing now someone to develop immunity to an antigen that has already been experienced before. Now, types of immunoglobulins, because now there are different classes, and they are used in different categories of diseases. So these are the components of the antigens. I mean the antibodies again. They are light chains and the heavy chains. Light chains are different, and they're the ones that confer the differences in the different classes of immunoglobulins. So heavy chains here for IgG or immunoglobulin G, we have the gamma heavy chains. IgM, we have the micro heavy chains. IgA, we have alpha heavy chains. IgD, we have delta heavy chains. And then immunoglobulin E, we have epsilon heavy chains. There are also light chains, which are kappa and lambda, as highlighted above. And this is a classical example of a protein electrophoresis that is showing the migration of these particular proteins, these chains, along the electrophoresis plate. And you can see that there's a peak at the albumin. This is the major protein in the body. Then there's another peak at alpha, peak at beta, uh, peak at gamma. This is actually depending on the quantities of the immunoglobulins in our system. And we cannot see even a peak for delta and a peak for epsilon because they are minute. They are minute. And the reversion of these particular quantities will mean that there is a problem with the immune system, or the body is actually trying to react to a particular disturbance in the system. So antibody classes, there are different classes as we've already seen. And I just wanted to highlight this table so that we can be able to appreciate the quantities of antigens, antibodies in relation to each other and how they're distributed in the body and their structural makeup, for example. So we have the IgG, which is immunoglobulin G, is the major one, has 3 heavy chains, and then IgM has 4 heavy chains or domains in heavy chains, constant domains in the heavy chains, and then the alpha has 3, delta 3, and then also epsilon 4. They exist as a gamma as a monomer. IgM exists as a pentamer, which is highly sensitive, and it can be able to act without the stimulation of anything else. It can work on its own. It can be able to activate the complement. It can work on its own as an auto agglutinating immunoglobulin, and it is actually the one that facilitates the cold reactions, cold agglutinations in IG, in red cell agglutination disorders. Alpha can be mono, di, or tri. And these are self-explained, and these exist as monomers. D and E exist as monomers. These are the normal serum concentrations, and we can be able to appreciate that IgG is the most abundant, followed by IgA. You can see this one here, followed by IgM. You can see this, followed by D, and then this is the list. This is the list. And the values of 0.04 micrograms per mil, you can see that this is actually too little. And this is in fact measured in nanograms, which cannot be able to be detected as a peak on electrophoresis. And then this is the actual distribution. So IgG is 80%, IgA 13%, IgM 6%. This is D is 1, and then this is E is 0.002. Now, on the individual immunoglobulins, I just wanted to highlight this one so that you can be able to appreciate this. IgG is usually some sort of a memory immunoglobulin, the most versatile and can carry out all functions of other immunoglobulins. The major one in serum and extravascular spaces. So this one means that in tissue fluids, in maybe synovial fluid, in ascitic fluid, in pleural fluid, this one will be plenty there, especially if those areas have been, exposed to something that has disturbed the immune system, that has attracted an immune reaction, for example. It's the only immunoglobulin that crosses the placenta. Very important to highlight. And this is why children cannot die on their own, because even though the immune system is not developed, the IgGs protect the babies. And they are also complemented when they take breast milk, because the breast milk now contains other types of immunoglobulins that we shall be able to see. That's IgA. And it complements now the function of immunoglobulin G. So it fixes the complement, although not very well, as compared to IgM, for example, and it binds cells and is a good opsonizing substance that enhances phagocytosis. So opsonization is just coating of antigens, so that now the phagocytes can be able to easily recognize that this is an antigen. It has been coated, it's been identified from self, and then it can be eliminated from the system right away. So these are the subclasses of IgG. There's IG1, IG2, IG3, and IG4. They are all working against different components here. IG1 is against protein antigens, and then IG2 against encapsulated bacteria. So if someone is having something like Cryptococcus meningitis, for example, they will be able to have IgG is elevated, IG2, and then others, even Mycobacterium tuberculosis, so long as they have some kind of an encapsulation, some cuticle, something that is protecting them against the ordinary function of the immune system, then IG3 act against protein antigens. Then IG4 works against allergens or chronic inflammations. The second class of immunoglobulin is IgM. It's the first to be met by the fetus and new B cells, and is stimulated by antigens. It's third most abundant in serum, as we saw before. And then
Hello,
it's a good complement.
Mr. Baraza.
Yes, please.
Mr. Baraza, there is some noise from your background. You can check on that.
Okay. All right. Sorry for that. All right, that one is rectified. Sorry, someone came into the office. All right, so the third most abundant IgG in serum, as we saw that, then good complement fixing, which leads to lysis of microorganisms through the membrane attack complex, and we know that one is the effector complex in the complement system. And then it's able to bind some cells via the FC receptors, and it can be able to agglutinate cells without any stimulations whatsoever. So that's why you can find RBCs agglutinating at room temperature, or they called agglutinins. They are agglutinating at room temperature or even lower temperatures. But when you heat them or you take them back to 37, then they can be able to dissociate these particular bondages, because they're just the pentamer molecule just acting and cross-linking these RBCs and making them agglutinate. And then B cells also have surface IgMs, which exist as monomers and lack the joint chain that can be able to link these monomers into the pentamer that we know. And they have an extra 20 amino acid in the C terminal that anchors it to the cell membrane. Those are the cells of interest in antibody actions. This is the pentamer. Pentamer means that there are 5. Pent is 5. This is one molecule of IgM. This is another one. This is another one. This is another one. This is the 5th one. They are all linked together by the joint chain or the J chain via the disulfide bondages or bonds. So they come together, and all these are antigen active or antibody active sites, these ones here, that can be able to bind antigens. So that's why this IgM is highly effective against in causing an immune reaction, because there are so many active sites for antigen binding. Now, IgM is the second most dominant immunoglobulin. What I needed to mention here is because IgM doesn't require really a lot of help from other immunoglobulins or other aspects of the immune system. It can be able to react on its own. That's why it is the most common immunoglobulin to be detected in acute infections, such as if you're doing your viral ELISAs or your ELISAs for IgM, you're going to consider IgM if you are going to detect maybe an acute viral infection, for example. You consider IgG if you are trying to detect a past infection, for example. Some people can do both IgG, IgM, ELISAs at the same time, but it depends on the clinical context or the picture that you want to highlight. But this one is the marker of acute infection. If you look at immunoglobulin A, you just think of the mucous membranes. So IgA is monomeric, is a monomer, and it is found in secretions as a dimer having a J joint, of course, if it's linked together. And then it contains a protein called the secretory piece or TPs that's made in epithelial cells and added to the IgA as it passes through this into the secretions, helps the secretory piece helps the IgA to move across the mucosa without degradation into the secretions. And then the second most abundant for that, and is the major Ig class in secretions. Secretions. This could be tears, could be saliva, could be colostrum, could be mucus, could be those mucoid fluids in the body. And it is important in mucosal immunity. It does not fix complement on its own. So it will need other immunoglobulins for it to be able to fix the complement or other facilitators in the immune system. So it is secreted, of course, from the B cells. B cells are the ones that are making all this, but it is this is the submucosa of maybe the gastrointestinal tract, for example, and we can see that these are microvilli. And if this is the epithelial layer of the stomach or the large intestines, then under this epithelial layer, we have the submucosa here, where there are a lot of lymphoid tissues. And these lymphoid tissues stores a lot of lymphocytes, B cells being the major ones. And they're going to produce the antibodies, and you can see these ones here. Dimeric, they can come here, but the polyantigen receptors at the basal side of the epithelial cells. Then this receptor will facilitate the entry of this IgG into the vesicle inside the epithelial cell. And this vesicle will be able to cleave this immunoglobulin and then joint it together to form a dimer here, which now will be able to enter into the lumen. This is the mucus secreting, membranes. And inside the lumen here is where the IgA will be able to impact its particular effector actions against protection of these linings from all kinds of invasions by microorganisms, especially microorganisms, because the GIT is highly exposed, the respiratory tract is highly exposed, and even the oral tract is usually highly exposed, and even the vaginal and the anal, canals, they're highly exposed. That's why we have mucoid surfaces in those areas, and they contain plenty of IgA for those particular protective functions. Then IgD is found in low levels. This is actually very minimal, and its role is not very, very much, established, but it's also produced, and it cannot be able to fix the complement. So this one is not going to be a major immunoglobulin there, but we're going to look at immunoglobulin E, which is very important in allergies, in parasitic infections, in helminths, and it is very, very low. You see the value, the levels of IgE is usually the least, measured in nanograms. But in terms of allergies, if someone is allergic to pollen, for example, or allergic to cold, allergic to anything that can be able to stimulate the immune system, then you're going to have a high level of immunoglobulin E. And I've seen guys requesting for these ones. I've seen doctors requesting these ones. And you'll find that if someone is allergic in those particular cases, you'll find elevated immunoglobulin E. And also, if there are helminthic, infections that are not in the gastrointestinal tract, because if you are doing your OC or stool for over and cysts, or maybe trophosis, you're not seeing anything, but there is high likelihood that this person is having helminthic infections that are tissue, that are, found in the tissues. One of the ways for you to tell that they are present, you could be able to look at the total quantitative immunoglobulin E as a marker of present, parasitic infections that are away from the usual places that we'll be able to detect them using conventional means, or maybe even histopathology itself when you look at the tissues. So if you're exposed to an allergen, this allergen causes the proliferation and increase in the secretion of IgE, globulin E, and the mast cells and basophils are the ones that are usually secreting these particular effector molecules are going to be able to act against these particular allergens. Histamines and other substances that are, work in allergic reactions. So mast cells will also be elevated. Basophilia, you'll also be having high basophil counts in these particular cases, and sometimes eosinophil counts also, because they're also containing granules that are rich in histamine. So whichever the immune cells that are producing histamine, then they're going to be elevated in cases of IgE elevations. Hypersensitivity. You see, we cannot talk about the immunoglobulins without mentioning some of the bad things that they do. The ones that we've mentioned are particularly protective aspects of the immunoglobulins, but there are other sides that are, as much as they're doing the protective work, they're also harming the body in different cases. So, for example, in hypersensitive reactions or hypersensitivity reactions, there are two types. Humoral types. Humoral, if you see humoral in any immunological literature, you'll just know that these are antibody-mediated reactions. Involves type 1, 2, and 3. Cellular mediated responses are involved in delayed type or type 4, which is it is cell-mediated hypersensitive disorder. And perhaps this is not what we're going to look at very much. We're going to concentrate on type 1, type 2, and type 3, because they are the ones that are related to the antibodies, the immunoglobulins that we're looking at today. So type 1 is also called the anaphylactic reaction. Or if you've heard of someone is in an anaphylactic shock, immediate shock, that when you're exposed to a stimulant, then you immediately run into a shock. You're not responsive, you're not having normal activities of your heart, you're not breathing. You see those signs of shock. They'll be able to appear immediately within 15 to 30 minutes of exposure to this particular antigen. And hypersensitivity, type 1 hypersensitivity is usually IgE mediated. This is actually what is present for those people who are, suffer from asthmatic attacks. There is no prior warning. You'll not know that you're going to suffer in the next 1 hour. But once you're exposed to an antigen or a stimulant, then you're going to develop an asthmatic reaction, an asthmatic response, because of the high secretions of IgE, and the immune mediators of this particular response are going to cause the effects of vasoconstriction, bronchoconstriction, and you're going to stop or you're going to have labored breathing, and you're going to faint. There is also the genetic basis where there is the ability to respond to antigen and produce IgE, both linked to genetic basis, of course. And there is a 50% chance that a child born to parents allergic to an antigen may have similar allergies. So these children may be born to parents, and they can inherit those particular complications. That's why you can find asthma running in a family. Then environmental conditions such as increased mucosal permeability, and this allows for increased entry of allergens into the bloodstream and leads to elevated IgE levels. Then concomitant factors such as simultaneous occurrence of certain viral infections in the upper respiratory tract, may also make it worse. And then pathogenesis by the B lymphocytes, creating a lot of IgEs, and they're going to cause cell damage through membrane lysis, influx of sodium and water, and degranulation of mast cells and basophils, as they release those histamines and other immune modulating substances. Then the release of granules containing histamine, serotonin, or vasoactive intestinal peptide, or VIP, causes the symptoms that we see. causes the symptoms that we see in those particular anaphylactic reactions. So, of course, increased vascular permeability, smooth muscle construction, and early vasoconstriction followed vasodilation, shock, increased gastric secretions, increased nasal and lacrimal secretions, increased migration of eosinophils and neutrophils at the site of local injury in the blood. So this is the mechanism, of course, and I'm not going to belabor on this, but it is self-explained that the plasma cells are going to be secreting a lot of IgE, and they're going to activate the mast cells of the basophils to release a lot of histamines and other immune modulating what? Substances. Now, type 2 reaction is a cytotoxic reaction that is also facilitated by antibodies and that attack the cell surface antigens on specific tissues and causes lysis of the target cell. So these are antigens that have already been bound on target cells or target tissues. And when they are detected, then these particular antibody reactions will be able to cause the type 2 hypersensitivity reaction, and we shall be able to have an immune reaction happening within 15 to 30 minutes. So etiology here. So there others like myasthenia and thyroiditis may appear longer because of the pathophysiology of the processes that are involved. It will need a lot of muscle destruction, muscle tissue destruction, or thyroid tissue destruction for you to have these particular symptoms. And there are other issues that can be able to be experienced in those cases as well. So etiology involves the complement system, tissue, macrophages, platelets, and natural killer cells, neutrophils and eosinophils, and IgE and IgM antibodies. And the antigen antibody binding forms a link between the antigen and the complement and causes activation of classical pathway of the complement that activates the membrane attack complex and the C3b, the complement 3b. Yeah. 3B is the one that's going to cause now the start of the formation of the membrane attack complex, because this one is going to work on the complement 5, splitting into 5A and 5B. And those guys in immunology, I think, can be able to relate this. So that's why CB is actually measured in the clinical setup. You can be able to see doctors requesting for complement 3B to assess whether the immune system is actually acting or it's acting normally. That's the function of slicing 5A and 5B, which are also working differently. 5B in membrane attack complex and 5A in chemotaxis and those chemical related immune reactions. So it is this is an opsonin and attracts phagocytes to the site of cell injury and initiates phagocytosis. So this antigen antibody binding is what causes all this particular reaction. And this is, the way it happens. And hypersensitivity is usually mostly affecting the kidneys. We have the glomerulonephritis, graft rejection. Yeah, this is the graft rejection. If you have had your kidney transplant and you have type 2 hypersensitivity against this particular graft, you'll be able to have the graft rejection here. Then we have the glomerular basement. Membrane antibody, which causes the good pasture syndrome here, all affecting the kidneys or the G3s, the ones that they're calling G3s, and they're going to affect your kidneys and you're going to have impaired renal functions. Examples of type 2 reactions are autoimmune hemolytic anemias, and you'll be able to see acute kidney injuries or AKIs in these particular reactions. That's because the most affected organ is the kidneys. And even the transfusion reactions, you'll be able to see although there is hemolysis, but there's also going to be acute kidney injury or AKI, where we're going to have elevated creatinine levels, elevated renal function tests, especially creatinine levels, and lowered glomerular filtration rate because the antigen antibody complexes are going to be affecting the kidneys most of the time. Then hemolytic diseases, which could be, antibody related, drug related, anything that is that's causing hemolysis, and also the hemolytic disease of the newborn. That involves the crossing of isoantibodies of the mother through the placenta into the baby, and of course now we'll be able to see a baby being born with features of hydrops fetalis. Then we have idiopathic thrombocytopenic purpura or ITP, where there is immunological destruction of platelets. And I've seen a case of this one here, where there is adequate, marrow activity for platelet excretion, where there is adequate macrophages, but there is reduced platelets in the circulation, which means that there is something that is taking the platelets away from the system prematurely because there is no bone marrow involvement in those cases. So these are those particular cases of ITP. Then leukopenia, agranulocytosis, that may cause autoantibodies to the leukocyte, causing the destruction of their destruction via the leukocyte, human leukocyte antigen, or the HLA. We have drug-induced cytotoxic effects, and antibodies are formed in response to penicillin, methyl dopa, rifampicin, and the actors heptans. So there are people allergic to these particular drugs. You give someone penicillin, and they're going to develop the symptoms classical of a type 2 hypersensitivity reaction. Others like Graves' disease in the thyroid gland, which happen later on. Myasthenia gravis happen also later on, and also male sterility or the sperm antibodies. The same thing happening here, where the antibodies that are acting against the sperm cells, yeah, and they're fighting the sperm cells. So this man will not have will have the spermatozoa, but they are not really going to work properly because the immune system is fighting against them. Then type 1 diabetes mellitus. There are also autoantibodies that are formed to react against the islets cell tissue or the islet cell cytoplasmic antibodies, which are also tested for. So if you find a test like this one here, it's just assessing the activity of these autoantibodies in the people who are having type 1 diabetes mellitus, those children. Type 1 diabetes is for children. Then hyperacute rejection reactions that involve antibodies that are formed against donor antigen, such as in kidney transplant rejections. Type 3 is immune complex mediated reaction. So type 1 is just immediate reaction, anaphylaxis. Type 2 is just antigens and antibody form that activate the immune system to fight. Then there is the deposition of antigen antibody complexes on tissues in type 3 hypersensitivity disorders. So there is the activity of antibodies here. This is followed by the activation of the complement system and an inflammatory reaction resulting in cell injury and causes now symptoms. These cell injuries are the ones that are going to cause the symptoms that people feel, or the people that can be able to, the doctor can be able to see that this is happening in this particular person. The onset is within 6 hours after exposure to the antigen. Etiology could be due to persistent low-grade microbial infection that stimulate a weak antibody reaction that will not lead to the elimination of this particular microbe. But the microbe will still stay in the body, causing a slow antibody antigen reaction. And this causes the antigen antibody complex to be deposited in tissues such as blood vessel walls, glomeruli, or even the joints tissues. And that is where now the symptoms are going to be felt, or to be felt by the patients that are affected. There can also be extrinsic factors such as environmental antigens that can be inhaled into the lungs from molds or fungi in the environment, or plant, or they could also be from plants or animals that combine with antibodies to cause this particular antibody complexes that will be able to be deposited in those regions to cause symptoms. And that is, I think this is the pathogenesis process where the immune complexes are formed by the interaction of soluble antibody and the soluble or and insoluble antigen, soluble and insoluble antigens. They fail to get removed from the body, right? That's number one. So that now they get deposited into the tissues, and then the complement now links the component, the FC component of the antibody now links to the complement and activates the classical pathway of the complement system, resulting in the formation of C3A and C5A and membrane attack complex. And C3A stimulates the release of histamines from mast cells and resultant in the in increased vascular permeability and edema. So there could be edema, but there is no renal implications. It's just the complement system working on its own through these particular immune reactions. 5A is a chemotactic factor or a chemotactic agent that causes attraction of neutrophils and other polymorphs or polymorphonuclear cells to the site where there is tissue injury. Now, this one causes could be reduced levels of neutrophil count in the peripheral circulation, but it just could mean that these neutrophils have left the circulation into the tissues or body fluids where they're now acting. Then accumulated neutrophils and macrophages in tissues release cytokines and then result in tissue injury or tissue destruction in type 3 3 hypersensitivity disorders. So you can see that this one, see, this is the pathogenesis process where there is an antigen such as a drug, and then an antibody such as IgM. IgM is able to bind so many antigens, and we saw why it can be able to do that. And IgG can bind few, and you can see that these are activating the complement system, and through that, these are attaching. Now, this complex here is attaching on the effector cells, the polymorphs, which are neutrophils, basophils, those are polymorphonuclear cell. And these ones are going to release a lot of immune modulating substances such as histamine and reactive oxygen species. These are ROS that are highly toxic. They're highly, they're toxic to the body cells and tissues. And when they get into the tissue, these reactive oxygen species are going to cause tissue destruction. This is the basic mechanism why type 2 hypersensitivity is going to cause tissue damage. Now, examples are things such as, antibodies against the glomerular basement membrane, or exogenous things such as streptococcus that are involved in the glomerulonephritis. Good pasture syndrome, and we saw that in glomerular basement membrane. And then we have the systemic lupus erythematosus, which is a very common autoimmune disease, and it's where there is a nuclear antigen, DNA or RNA. Then there is the formation of antinuclear and anti-DS DNA, anti-double-stranded DNA autoantibodies. So if you're doing your anti-nuclear antibodies and you find although anti-nuclear antibodies will just be positive, but if you're doing your ENA profile, for example, and you find and you find some positivity, you will now want to work out and find whether this is a SLE or if it is any other immune reaction. You can also do a direct anti-dsDNA antibody, and you guys have seen these tests. I just wanted us to highlight this so that we can know that these tests are here because they are meant to do this, so that we can be able to correlate whatever that we're doing with the clinical picture of the patient. And as we report, you know what actually you're going to impact in the patient management. So anti-double-stranded DNA antibodies are there in systemic lupus erythematosus, because this one affects the nucleus. And you can be able to see the anti-nuclear antibodies are going to be positive, especially with the homogeneous pattern. And then rheumatoid arthritis can also be there, and where there is the nuclear antigen. And then the farmer's lung with the actinomyces, contaminated haze that acts as an antigen. Now you can see that. So that these antigens are going to act with the antibodies secreted in the body. There is the polyarteritis nodosa, the Wegener's granulomatosas, and with antineutrophil cytoplasmic antigen. There is also antineutrophil cytoplasmic antigen, or ANCA. That's also tested routinely in these labs, and you'll be able to know that this one is also going to help in the detection of polyarteritis nodosa, or this particular Wegener granulomatosas. Then this Henoch Schönlein purpura, which is a respiratory, in which the respiratory viruses act as an antigen to cause this particular symptoms. Yeah. Then the antigens, but the body will now produce the antibodies to effect this particular mechanism. Antibody. Excuse me. Typhoid doesn't involve any. This one is just involving the dendritic. This could be dendritic. They look like dendritic cells. This one is a CD4 cell. Then this one is the tumor necrosis factor that is stimulating the excretion of this particular, effector cells, such as monocytes, could be neutrophils, could be macrophages. And this one here leads to formation of a giant multinucleated cell in these tissues here. So you see those kinds of reactions and these kinds of things, you'll know that this one is a type 4 hypersensitivity reaction that is cell-mediated. Could be having lymphocytes such as these ones here, or actually having giant cells that are, macrophages that are activated. They can be able to work against a wide variety of antigenic stimulants. And I'm not going to concentrate on these ones because we were looking at the antibodies in this particular presentation. This is a summary, and this is also a summary of the same thing that we've been able to look at. And some of the autoimmune diseases, things such as things such as I need to fight to things such as SLE and Sjögren's syndrome and myasthenia gravis. I'm looking at the basic mechanisms within which these particular autoimmune diseases occur. And autoimmune would mean that the body, the immune system is acting against these particular antigens because it is failing to distinguish between self and unself, stimulants. Things that are going to stimulate the immune system by formation of autoantibodies that are going to act against body's own tissue antigens. The mechanism here will mean that now somehow the body is going to lose the ability to recognize the self antigens as self. And it will be able now to mistakenly identify these self antigens as foreign, and then be able to cause an immunological reaction against these particular antigens. Now, how does that occur? We have three basic ways in which it occurs. There is clonal elimination, and by the way, T cells are trained in the thymus gland before they are released in circulation to go and act in affecting the immune system, both cellular. Of course, this is cellular, and they can also help the B cells. The T helper cells help the B cells produce antibodies. Before they are trained to do that, while still in the thymus gland, there is what we call clonal elimination of T cells. Maturing in the thymus and acquiring the ability to distinguish self from non-self. So there is an elimination of T cells that cannot be able to distinguish foreign and non-self. So those T cells are eliminated from the system. The works of God, the miracles. And then there is clonal energy, where T lymphocytes, which have acquired the ability to distinguish the self antigens from non-self antigens, are not eliminated, but instead they become non-responsive and inactive to self-antigens. Look at that. So this is clonal energy. Energy is taking away the ability of this particular lymphocyte now to act against self-antigens. Then there is also the suppressor of T cells, which now will allow for the tolerance, to be achieved by the suppression of specific T cells, which do not allow antigen responsive cells to proliferate and differentiate. Right. So there is suppression of T cells to allow the self antigens to exist in the body as being part of the self system. Those that are acting against these antigens are eliminated like that. They are suppressed. So these are the basic mechanisms, and they're all affecting the T cells. So autoimmune diseases are going to involve T cells in much of the discussion, and T cells also affect the B cells in helping the antibody secretion. So this is the way autoimmunity is actually prevented, and it can be prevented through sequestration of autoantigens. Those autoantigens are sequestered and eliminated. Generation and maintenance of tolerance or energy, just as we saw. Then regulatory mechanisms such as those that limit the response of the immune system, such as immunological, genetic, or microbial factors that will allow now autoimmunity to be that now will prevent autoimmunity. Then autoimmune can set in because of polyclonal activation of B cells, right? Directly leading to the bypassing of T cell tolerance that we saw in the thymus. Then generation of self-reacting B cell clones that can lead to the bypassing of T cell tolerance again, decreased T suppressor and increased T helper cell activity, self-explained. Then fluctuation of anti-idiotype network control that may cause also failure of the immune system, tolerance. Sequestered antigens can also be released from the tissues. Yeah. So if they are sequestered within the tissues, if they are released, then they become foreign. Yeah, because they are no longer inside the tissues. When they come outside of the cells, they are now considered what? Foreign. For example, if something is in the environments in the body that are immune tolerated, yeah, there is a blood barrier, sort of kind of a mechanism that prevents the immune cells from reaching to those particular areas, such as a blood-brain barrier, such as the blood-testis barrier, and those kinds of things. So if there is release of these self-antigens from, for example, from the testicular trauma, it will cause the formation of anti-sperm antibodies that will now be able to work against the sperms inside the testicular tissue. Because now this one has released these antigens. They're no longer self, but now the system will go to acknowledge them as being foreign. Genetic factors such as expression of class 2 human leukocyte antigens that also on tissues involved in autoimmunity and higher incidence of autoimmune disease in twins, which means that there is a genetic reason why these twins are going to have increased autoimmunity within themselves. Then microbial factors such as infection with microorganisms such as viruses, and we have Epstein-Barr virus and others such as Streptococcus and Klebsiella and Mycoplasma. And we know that these organisms release toxic substances that also mediate the immune activity. These autoimmune diseases could be organ-specific or localized, such as on thyroid, pancreas only, or adrenal, alimentary canal, or maybe the blood cells, or various tissues or organs. They can also be organ-specific, or now this one is systemic diseases, which in which a number of autoantibodies are formed that react with antigens in many tissues and thus cause systemic lesions. So individual examples, and we're looking at systemic lupus erythematosus, and this is a major autoimmune disease. This is a major one. And is an example of systemic autoimmune or collagen disease that derives its name from lupus, from the Latin word meaning wolf, right? And there is two types, systemic or discoid, all right? Discoid is localized just within the face. And some people describe it as a slap on the face kind of a reaction. So people have SLE, when you look at their face, they're like been beaten up, especially those ones who are light-skinned. Those ones who are dark, you may not be able to appreciate that particular effect very well. The melanin and the body itself, it will not allow you. But those who are light-skinned, or those who have bleached themselves, you'll be able to see that particular reaction. And then the systemic or disseminated disease that can have acute or chronic inflammatory lesions that are widely scattered in the body, and there is the presence of various nuclear and cytoplasmic antibodies in the plasma, and you can be able to test for those ones. Screening using antinuclear antibodies, then confirming using the extractable nuclear antigens, right? Which is a panel of tests that we're also going to look at the end of this particular discussion. So discoid only affects the face, but disseminated affects the entire what? The entire bodies. And systemic lupus erythematosus, my friends, has very non-specific symptoms, and you can see these symptoms are very non-specific. Every system has its own symptoms. So like for the lungs, it will have pleuritis, pneumonitis, pulmonary emboli, pulmonary hemorrhage. In the blood, you can have anemia, high blood pressure, and so many other conditions, depending on where these particular immune, deposits are. And causes could be the genetic, where there is the predisposition to develop autoantibodies to the nuclear and cytoplasmic antigens in SLE due to the immunoregulatory function of class 2 HLA genes that are implicated in SLE. Environmental factors such as drugs, such as penicillin. There are people who are allergic to penicillin and certain infections, and you can see these ones here. And even some hormones. Some people also are allergic to some hormones. If you're given the injections, then they can be able to develop some reactions. That's why it's important to know which type of hormonal contraceptive or method you're going to adopt, because you could be allergic to one hormone and it will be able to cause these kinds of symptoms. And then pathogenesis involves the autoantibodies against nuclear and cytoplasmic components. Diagnosis is done through the anti-nuclear antibodies and antibodies to double-stranded DNA detection and titration. So you can detect and also do the titer of these particular things so that you can be able to show the severity of tissue damage. And these ones are very specific. These are others, I'm not mentioning on that. And there's also Smith antibodies also that are involved. Others are anti-ribonucleoprotein, seen in 40% cases of SLE. And antihistone antibody, which is antibody against histone associated with DNA in chromatin, and it's particularly in cases of drug-induced lupus in SLE. And phospholipid antibodies and lupus anticoagulants, and these are tested to assess for thrombotic complications in SLE. And I've seen cases of the lupus anticoagulants being, requested, and these are the ones. The antibodies, anticoagulants are antibodies anyway. And then anti-ribosomal P antibody which is an antibody against the protein in ribosomes, and is seen in central nervous systems of people with lupus. And these autoantibodies can come from polyclonal activation of cells that are brought about by an inheritance of defective B cells, stimulation of B cells by microorganisms, and T helper cell hyperactivity, and T cell suppressor defects that happens now in the thymus. Very non-specific, very, very non-specific. Features of SLE, most common in women in the second and third decades of their lives, in 20s and 30s. Target organs are musculoskeletal system, skin, kidneys, nervous system, lungs, heart, blood vessels, GI, and hematopoietic system. Causes fatigue and myalgia that's present in most cases. And then severe form of illness will also occur will also occurs with the fever, weight loss, anemia, and organ-related manifestations, and has long flares or flare-ups and remissions and renal failure in most of the cases, and even death. Scleroderma is sclerosis, sclerosis, and this is just characterized by progressive skin fibrosis. It's an autoimmune disease, and CREST is the abbreviation of symptoms that are, characteristics of the sclerosis, which are calcinosis, deposition of calcium in tissues, Reinhard phenomenon. Those guys who have been attacked by a frostbite. It's not very common in the equatorial regions, but if you have gone for a mountain hiking and you have seen that your fingers are numb, they're green, they're bluish, yeah, that's what we're calling Reinhard phenomenon. And then esophageal hypomotility, where there is difficulty in those activity of those muscles. You can't swallow properly. Sclerodactyly, the fingers are affected. You can't close or maybe stretch them. Telangiectasia, telangiectasia is abnormal vessels around the surface of the skin. The etiology has genetic, will also be having infectious implications such as cytomegalovirus, and you can be able to test for that using ANA test or antinuclear antibody test. And this is the mechanism through which it is working. And you can see these pictures here. This one is not rheumatoid arthritis. It is scleroderma. And you can see this is just, it's affecting the muscle, not the joints. And you can see that these inflammations are on the joints, yes, but they're not affecting the joint, the bones themselves, as related as arthritis does. But this is affecting the muscles. And you can see that there is a claw-like flexion, deformity on the hands, then had phenomenon, bluing of the tip of the fingers, esophageal fibrosis, malabsorption syndrome, respiratory distress, malignant hypertension, pulmonary hypertension, and biliary cirrhosis. Myopathies, myopathies are a group of conditions that are, they lead to progressive skeletal muscle weakness, such as polymyositis, dermatomyositis, and inclusion body myositis. They are associated with autoimmune diseases or collagen disease, and the presence of autoantibodies against nuclear and cytoplasmic antigens are detected. Then the presence of immune mechanisms in dermatomyositis is observed in B cell infiltration in the lesion. So if you're looking at the lesion itself, there is a chronic sort of inflammation where there is a lot of B cell infiltration. And when you do immunohistochemistry for B cells, you'll be able to see that these are not T cells in the tissue; they are only B cells, antibody secreting cells. And in myositis and in inclusion body myositis, T cell mediated cytotoxicity is also implicated, as seen by CD8 positive T cells along with macrophage in the lesion. So this is also through histochemistry. This is the mechanism through which the muscle tissue is going to be damaged or hurt, where there is the muscle factors that are going to cause activation or active chemoattraction of this particular polymorphs, such as neutrophils, monocytes, and those ones will leave the circulation through chemotaxis, chemical attraction, to the site where there is this particular antigen reaction within the muscle tissue. You can see here. Now, this one will cause an acute inflammatory response where there is going to be a lot of neutrophil buildup in these muscles here. And then the immune cells factors could lead to, damage of the muscle tissue. And you could be able to see the pericytes. These are repairing cells. The pericytes increased in these particular cases, and you'll be able to appreciate that. The muscle tissues can also lead to either pathogen clearance or those antigen clearance or chronic inflammation. That is now the problem that will lead to fibrosis and what we've just seen in the previous picture or the previous slide. Clinical features include progressive muscle weakness, mainly proximal muscles, skin rashes, typically with the heliotropic erythema and periorbital edema, around the eyes. I think this is seen, I've seen a lot of some people having a lot of periorbital edema. Perhaps they could be having these myopathies. They can't even open their eyes very well. Yeah. Because the muscles have been affected. They have no elasticity. The muscles are not working properly. They're having fibrous tissues deposited there. They're not contracting and expanding properly. Then dysphagia problems with the pharyngeal muscles, then respiratory dysfunction, and this is also associated with deep-seated malignancies. Sjögren's syndrome is the last syndrome I'm mentioning, and then we'll look at the antinuclear antibodies and the NR profile as we finalize. They are characterized by the triad. Three things. When you see Sjögren's syndrome, you just think of dehydration. Somehow, it's just dehydration, where there is dry eyes, keratoconjunctivitis, Zika, dry mouth or xerostomia, and rheumatoid arthritis, dry areas. And it's affecting ladies mostly. I'm not saying that they will be dry, but it is dryness generally. You see Sjögren's syndrome, you just think of dryness. So this it's characterized by the Zika syndrome, which is just involves the dryness of the eyes and the dryness of the mouth. And then the etiologies of the B cell, B lymphocyte hyperactivity as seen in with a rise in monoclonal immunoglobulins. There's the presence of antinuclear antibodies in about 90% cases. So if you do an ANA, it's going to be positive in 90% of the cases. RF is also positive in 25 cases of these particular things here. So that's why your RF will not be very, very specific for rheumatoid arthritis only, but there are other immunological autoimmune diseases that are also going to be implicated in a positive RF disorder. Then infiltration by T lymphocytes in exocrine clans, and these are associated with certain HLA class 2 antigens, and it's also associated with other autoimmune diseases. So you may find Sjögren's diseases in SLE or other myopathic diseases. So symptoms, I said that we just have dryness, we have dry eyes, dry nose, dry mouth, dry skin, dry throat, dry everywhere, mostly dries, and it's affecting ladies mostly. So that's basically what Sjögren's syndrome is, and these are the clinical features. And a brief mention on the application of antibodies that applied in infectious diseases diagnosis. We have serologies, ELISA, everything. Autoimmune diseases, as we've seen, and then immunodeficiency disorders, where there's actual quantification of the different classes of immunoglobulins. Could be immunoglobulin A. You're looking at the mucous surfaces, immunoglobulin B, M, the ability for the body to react immediately, and the IgE, IgG. Then in oncology, of course, in a marker of monoclonal proteins or polyclonal, and also in tumor staging. It's also applied in allergic testing, such as the measurement of IgE to identify allergens in patients. Modalities are such as ELISA, Western blot, immunofluorescence, and immunoelectrophoresis or fixation electrophoresis for monoclonal gammopathies. Rapid antigens, we've seen these ones here, and tests such as ANA and anti-CCP or P-ANCA, uh, uh, plasma. This is the P-ANCA antiphilic cytoplasmic antigen, C-ANCA also, antibody tests in transfusion medicine, CUMS, and rapid antigen or antibody tests, ELISA immunofluorescence, chemiluminescent immunofluorescence assays, and immunohistochemistry and immunocytochemistry. So those are the tests that we can be able to do to highlight the individual autoimmune diseases or antibodies or antigens that are actually present. Now, for those guys who are doing these autoimmune diagnostics, some labs are privileged to have these things here. And this is an example of an immunological reaction for those guys who are doing anti-nuclear antibodies. Anti-nuclear antibodies, they can either be positive or negative. Some guys will stop there, but others will be able to qualify this positivity into such kinds of the entire thing is a nuclear. These things are staining, they're affecting the nucleus. They're detecting things that are present in the nucleus. So the cytoplasm is not going to be seen in these cases. The entire thing that you're seeing, the greenish thing there, those are nucleus. And then could be homogeneous, and you can see homogeneous just green everywhere. Could be speckled, and you can see the speckles. Could be peripheral, you can see around the periphery of the nuclear membrane. Could be also nucleolar, and you can see inside the nucleus, there are nucleoli. And you can see that these are acting against the nucleoli. So this pattern would mean something. So if you're seeing homogeneous patterns present mostly in SLE, and sometimes in mixed connective tissue disease and autoimmune liver disease. Speckled pattern is also seen in lupus and Sjögren's syndrome and scleroderma. Peripheral pattern here, and coupled with the double-stranded DNA antibodies or anti-dsDNA antibodies are seen in systemic lupus erythematosus, and then nucleolar pattern is seen in what? In scleroderma. So if you qualify it such in that way, and then when the report goes out, it might even negate the need for an extensive what? An extensive NR profile. Because if the NR is positive, then you can be able to do an extractable nuclear antigen what? Profile, which has all these particular antigens here. These antigens will mean that the patient is having these particular diseases here. For example, Smith antibody will be present in SLE, ribosomal P in SLE, Sjögren's syndrome, A or SSA and SSB in SLE and Sjögren's syndrome, you can see that. RO52 in Sjögren's syndrome and SLE and mycystis. And the centromere B limited to scleroderma. RNP in SLE and scleroderma in mixed connective tissue disease. Then SL17 systemic sclerosis, then JO1 in polymyositis and antisynthetase syndrome. So these are basically the antigens that you can be able to test with using specific antibodies in your extractable nuclear antigen panel, and you can be able to arrive at a diagnosis using the immunoglobulins as part of what we have just covered here and as part of what we covered in immunology. So these are basic cover-up of what the immunological reactions are and how we can be able to customize them to be able to use them and apply them in diagnostic medicine, and also help the patients and help the correlation of what we're finding in autoimmune disease diagnosis with what actually the patient is actually experiencing in their daily, in their clinical symptoms. Cellular mechanism, I've not looked at them here because they are beyond the scope of this particular topic, but maybe that one could be later on. And this particular time, I'd like to take the mantle back to Arthur Emari. That was all from me, and perhaps you can take over the session and handle it from there. Thank you so much for listening in.
Thank you, Mr. Baraza. That was very strong, full of energy. I think all of us can attest that we have learned. We have learned a lot of information. And so what we need to do is to do the practical part of it at our labs. So without wasting time, because we've already gone past our normal presentation time, we have eaten into the question time. So allow me to go into the questions that we have so that you can also have a look at them. As we have Josephat Rotich, yes, Here's a question, and the question goes: why is IgM considered a marker of recent or acute infection? Why is IgM considered a marker of a recent or acute infection? Back to you, Dr. Ari. Doc, have you had the question?
Yes, I've had the question. I think I had muted myself. Now,
Oh, sorry.
uh, yeah, so IgM is a pentamer, which means that it has the ability to pick up anything that doesn't require prior sensitization, prior or any help from any other helper cells. IgM in itself is pentameric, so it will be able to. It has a lot of antigen binding sites, and it can be able to attach to an intruder or an antigen very fast as compared to other immunoglobulins, which have very few antigen binding sites as compared to the pentameric IgM. So that's why it is going to be the first immunoglobulin or Ig to be detected in acute infections as compared to the others. I think
Very
that is
well.
all on that one.
Thank you for that response. Let's look at our second question from Jackton Indangasi. And the question is it possible to distinguish between antibodies produced by vaccines and those produced by antigens? Back to you, Doc.
Antibodies produced by vaccines and antibodies produced by antigens. But I think
Yes.
vaccines are also antigens. So I don't think there's a way of differentiating, because the immunological reactions for these antigens is going to be the same. If we are targeting to stimulate the body against to produce antibodies against hepatitis, for example, as an antigen, then we're going to have an inactive form of an antigen that's going to mimic the virus itself inside the body, which is a vaccine, and it's going to elicit the immune response. It's going to be similar to the actual virus if it was, the one that's affecting the body. So that now the body is now programmed to kind of cause a stronger reaction when there is an actual exposure of the same kind of antigen later on. So the same mechanism that is involved in vaccination is the same mechanism that's involved in the actual infection or the actual antigen antibody reaction. So you will not be able to differentiate that. Perhaps you can be able to detect an increase in those particular antibodies as a response to vaccination because of that particular antigen antibody reaction. Back to you, Arthur.
Thank you. Thank you. Francis Mambele says, good presentation. And the question goes, which immunoglobulin is specific for allergic reactions? You had said that, but I think you
Allergic,
can just make a repeat.
yeah,
Allergic reactions.
allergic reaction is just IgE.
IgE, thank you. We have Francis Mambele again. Which antibody is used to test for active infection? Active infection?
IgM, as we've said.
Okay. Somebody wants to understand the meaning of transcytosis.
Oh, transcytosis is just a process by which molecules are moved through a vesicle from one side of the plasma membrane or cell membrane to another side of the cell membrane. Basically that. So in this case, we're talking about antigens or an antibody, whichever the molecule is.
Yeah, thank you. Transcytosis. That was a question from Elika Nangila. Thank you,
All
Elika,
right.
for that question. We have Catherine Ditti. Catherine Ditti says, awesome presentation. Oh, you asking about your CPD points for yesterday? Okay. You can fill the complaint form and then reach out to us. We'll be able to check on your behalf if you have them. But meanwhile, you can as well check on your email and your inbox and also your spam if uh, they might have been directed to that place. So you can check on those particular area. Now we have Francis Mambili again. The question is, how do complement system play a role in antibody antigen reaction? Let's talk.
Um, complements complements are the ones that are activated after the antigens and antibodies have interacted. So after the antigen antibody reaction is when we have the complement activation to affect the function of the complement. So it doesn't happen the other way around. Yeah, there are some other pathways for the complement which does not involve the immunological maybe antibody input, but basically using the classical complement pathway, you will need an antigen antibody to activate the complement system to lead to the formation of the membrane attack complex. So basically, that is what it is there.
Well, very well. We have Electin Silaha, and the question is ANA test specific to a certain disease or it's just suggestive?
ANA is ANA is not specific per se, but if you go ahead and qualify the kinds of reactions that you're seeing, if you're seeing a homogeneous pattern, if you're seeing a speckled pattern, then it's going to help point to specific autoimmune reactions, autoimmune diseases. So there are different patterns that are seen in autoimmune, in anti-nuclear antibodies that are specific to some kind of an autoimmune disease, but they're not specific per se. For you to confirm that, you'll need now further testing using maybe an extractable nuclear antigen panel to actually confirm that this is the antigen that is causing this reaction, and it is not a cross reactivity maybe from another antigen. So it's a pointer, but you'll need the NR profile to confirm.
Yeah, thank you. A question from Kenneth Okubo, and the question is GBS, Guillain-Barré syndrome, is in which class and how is it detected in laboratories in a laboratory setting? Allow me to repeat the question. GBS,
Yes, please.
Guillain-Barré syndrome, is in which class and how is it detected in a laboratory setting?
Okay, I think I've not mentioned specifically about this GPS Guillain-Barré syndrome, but it also an immunological reaction, and it can be able to be detected through an increase in protein, there's especially CSF protein levels. So it could be the proteins could be antibodies themselves. You can even do an electrophoresis on these proteins to see the particular components of the proteins, but there'll be increased cerebrospinal protein levels in the cases of GBS Guillain-Barré syndrome. And further analysis on the proteins maybe can reveal whether they are antibodies or albumin or any other proteins in the body. Thank you.
Okay, thank you. We have John Wanyoni, and he says, thank you for the wonderful presentation. My question is, what test panel would you recommend for a case of itchy skin rash associated with mild edema of unknown cause? I repeat, thank you for the wonderful presentation. My question is, what test panel would you recommend for a case of itchy skin rash associated with mild edema of unknown cause? Back to you, Doc.
Okay. Now, itchy skin could be anything. Could be an allergic reaction, could be some immunological response to mostly allergens. And there are different modalities. You can do a cytology of that vesicle. If it's a vesicle that's containing a fluid, you can do a cytology on it. There are specific, and I mean, staining uh, modalities for that kind of thing, and you can be able to see cellular morphologies that can be able to differentiate between whether it is because of an infectious disease or it is because of just a reaction, because of a reaction against what? A viral or not a viral, not an infectious process, and a reaction against any other allergen apart from or actual an infection. So there's a diagnostic modality, but that one will involve cytological examination of that particular fluid, or even if you can do a punch biopsy of the skin, then you can even have it done histopathologically to determine the cause of that particular problem. But that one is in histocyto, maybe.
Thank you.
Yes.
Colleagues, we appreciate the good work done by Mr. Baraza, Cosmas, and I believe we've learned a lot today. Before we end this session, allow me to bring him back so that he can do his parting shot, and then we will conclude today's webinar. Welcome again, Mr. Baraza.
Okay, all right. Thank you so much again for having me today. It's always a pleasure to share knowledge, and I believe that we can be able to apply it wherever we are working, so that we can be visible in the multidisciplinary healthcare teams. So I wish you all the best in your future learning in the CPDs, and all the best in your practice. And let's embrace MLS as a unique profession and make it grow. Thank you so much.
Yeah, thank you, Doc. Thank you, colleagues, for turning out in large numbers to attend this particular presentation. We invite you again tomorrow so that you can as well join to a learning session that we will organize same time tomorrow. And so we urge that you register early enough and prepare to attend. On behalf of Lab Medicine Society of Kenya, we thank you a lot for attending, and we welcome you again tomorrow. Otherwise, we wish you a good evening and be safe wherever you are. Thank you.